Hello everyone. Welcome to part 2 of ASTHMA. If you haven't watched the part 1, the link is in the description. So please go back and watch that video first before you watch this. In this video, I'll be mainly talking to you about the symptoms, the signs, differential diagnosis and diagnosis of asthma. Talking about the symptoms, a patient coming to you with asthma may mainly present you with recurrent wheezing, dyspnea, coughing, difficulty with inspiration, and or thick sputum difficult to expectorate. Cough variant asthma seen especially in children may only have a recurrent non-productive cough. It may be worse at night and during early morning hours. It may be intermittent or resolve spontaneously with treatment. So this is a picture which shows the main symptoms and signs of asthma, that is shortness of breath, difficulty breathing, night cough, dry cough, night cough, wheezing, and chest pain. Signs: asymptomatic when under control, expiratory with or without inspiratory generalized wheezing and bronchi, and hyperinflation. Differential diagnosis: upper airway obstruction by tumor or laryngeal edema causes stridor rather than wheezing. Flow volume loop shows a limitation in flow in both inspiratory and expiratory curves. Bronchoscopy confirms diagnosis. Foreign body aspiration shows localized wheezing. Left ventricular failure. Wheezing is accompanied by crackles. Vocal cord dysfunction. Eosinophilic pneumonia and eosinophilic granulomatosis with polyangiitis may present with wheezing. Chronic obstructive pulmonary disease shows wheezing without significant reversibility. Diagnosis of asthma: apparent by symptoms and signs, confirmed by tests showing airflow limitation, reversibility, diurnal variation, and or airway hyperresponsiveness. Lung function tests showing airflow limitation, reduced FEV1, reduced FEV1 by FVC ratio, and reduced peak expiratory flow. The lung function test showing reversibility, an increase in FEV1 by greater than 12% or 200 ml. 15 minutes after shock acting beta 2 agonist therapy or 2 to 4 weeks after daily oral corticosteroid therapy. Lung function test showing diurnal variation by peak expiratory flow measurements twice daily. This is a graphical representation of a lung function test showing flow volume loops with an obstructive pattern and a reduced maximum expiratory flow. So on the left hand side of the graph is a patient with obstructive lung disease such as asthma or chronic bronchitis or emphysema, whereas on the right side it's a graph of a patient with restrictive lung disease such as interstitial lung disease. So, on the left side, on a patient with asthma, the total lung capacity is going to increase, whereas the FEV1 by FVC ratio is going to decrease. Airway hyperresponsiveness: more than 20% reduction in FEV1 with methacholine or histamine challenge or exercise testing. Rarely used when lung function tests are non-diagnostic. Hematological tests are not usually helpful. Chest x-rays may show hyperinflation, which I already described in the signs of asthma. So it may show hyperinflation and help to rule out pneumothorax or pneumonia during exacerbations. Skin test is not usually helpful in the diagnosis of asthma. Positive tests may allow the implementation of allergen avoidance measures. Exhaled nitric oxide may be helpful in assessing the adequacy of treatment with inhaled corticosteroids. Appropriate inhaled corticosteroids use reduces exhaled nitric oxide levels, which reflects the control of eosinophilic airway inflammation. With this, I end the part of this video. Please watch my next video about treatment of asthma. Thank you.